cancer, and let's talk about the effects of GcMAF in advanced cancer patients. Why advanced cancer patients? Well, the answer is easy. As the speaker before me said, this type of treatment usually comes after other treatments have been tried or after other treatments have failed. This didn't happen in the times of William Coley at the end of the 19th century for the very simple reason that there were no other treatments available for cancer, and cancer was diagnosed by bare hands or naked eyes only when it was advanced. So we're now back in the situation where William Coley was. This paper has been published in a journal named Immunology. So the name of the journal tells you what is the journal about. And this particular paper on GcMAF, on the effects of GcMAF on nagalase in advanced cancer patients, was thought to be so important by the editors of the journal that they wanted to put the molecular structure of GcMAF in the front cover. Again, for scientists, for the vanity of scientists, this is a kind of important achievement as to be on the cover of Time for a businessman or for a politician. Talking about the effects of GcMAF on advanced cancer, we have to mention the very first paper describing those effects that was published in the International Journal of Cancer in 2007 by the research group of Professor Yamamoto, where he described the eradication, he used that noun, the eradication of metastatic breast cancer with GcMAF. But I will not talk about this paper now. I wish to focus your attention on the paper that is reported below. And I will talk now, because when I will show you the slides just in a few minutes, you will not be listening to my words any longer. So let me tell you what did these scientists from Japan do. First of all, this research group from Japan has nothing to do with Professor Yamamoto. They worked in Japan completely independently. And as you know, in science, when you achieve results, the same results by two independent groups, this gives much more credibility to whatever results are presented. I wish to draw your attention on the institution where these scientists come from. You may recognize the Atomic Bomb Institute in Nagasaki, one of the most prestigious, for, of course, dramatic reasons, research institutions in cancer from all over the world. You'll know what happened in Nagasaki in 1945. Because of that, all top cancer scientists went there and still there, observing the effects of ionizing radiations released by the atomic bomb on human populations. So we're talking about the most prestigious oncologic institutions in the world. These scientists, what did they do? They simply transplanted into receptive mice a human tumor, hepatocellular carcinoma, and they let the tumor grow. Then they divided the mice into groups. In one group, they did not do anything, and in the other group, they administered subcutaneously GcMAF for 3 weeks, every day for 3 weeks. I think that the next slide doesn't need any explanation on my part. You can see by yourself, here we're not talking about fancy tumor markers. We are not showing graphs or histograms. Here we are showing real tumors. And you can read that you can see that in the non-treatment group, this is the size of the tumor. In the treatment group, if you go by volume, you have a 90% reduction of the size of the real tumor in 3 weeks of daily subcutaneous injection of GcMAF. I think this is pretty dramatic. This comes from a completely independent research group. So I think that you cannot but believe your eyes when you see these tumors. If you look at the quantity, they injected 40 nanograms per kilogram per day. In a human, this would be equivalent to 2,800 nanograms per day. Definitely much more of the original indication put forward by Professor Yamamoto, who suggested to inject 100 nanograms per week. So here we will have to discuss about quantities and activities. So these are the results obtained with a human tumor transplanted in mice in Japan. And now we move to Switzerland, where, as Mr. Noakes said, we have our treatment center. And again, this has been possible thanks to the courage, the vision, and the persistence of Mr. Noakes. And here we can see patients, we can treat patients with the new molecules of GcMAF, but later on I will explain why they are more potent. There is a reason. As Mr. Noakes said, I have a double affiliation. I am a clinical radiologist, and in addition, I am a professor of molecular biology. So here I'm talking as a clinical radiologist with a specialization in ultrasonography. I don't know if you can see anything. Most likely the light is not the most appropriate. We radiologists, we like to live in the dark. But this is a breast cancer patient, very nice lady, age 60 or 61, stage 3 cancer with no metastasis. You should be able to see that the cancer has a triangular shape here. This is the skin of the patient. This is the pectoralis muscle. And here we take a measurement with the ultrasonography. We use the ultrasonography system to inject the GcMAF very, very close to the tumor, as close as possible to the tumor. And then we take a measurement, and this is much worse. And after 2 weeks, we see a decrease in length of the tumor taking this side from 179 to 136 centimeters. I must tell you that this advanced and sophisticated ultrasound equipment is able to discriminate 1/10 of a millimeter, so we can be as precise as to go down to 1/10 of a millimeter. But what is most important is that if you could see something, you would have seen that this area here is round, is spherical. We, as radiation oncologists, we interpret this as the growing front of the tumor. The tumors are never symmetrical, and there is a part that it is growing more than other parts. The part that is growing more, it is spherical. This lady is lucky because the part that it is growing grows toward the skin, not toward the inside, not toward the pectoralis muscle. You can easily make this, consider that this is a sphere, and if you calculate the diameter of this sphere, so this is a magnification of something that you are unable to see, but please believe me. So this is the sphere, this is the growing front of the tumor, goes down from 4.7 millimeters to 3.5 millimeters in volume. This is a reduction of about 58% in 2 weeks. So we can say that we are observing results that are fully consistent with what the Japanese team had observed in mice transplanted with a human tumor. In this lady, there were several lesions in the right breast. So this lesion here, you can see slightly better. It has more or less the shape of the continent of Africa. This was a secondary lesion. Again, this is the skin, this is the pectoralis muscle. This was 4.7 millimeters, went down to 4.0 millimeters. The reduction in volume is about 34%. Again, consistent with what the Japanese had seen in mice. This is another lady. We're talking about stage 4 cancer with metastasis in her bones, in the vertebrae, in the pelvis, and in her lungs. This is the primary tumor. You can see the reduction in length from 169 to 129. I read it better on my computer. And here, I will show you in the next slide, if the lights allow, that the growing part of the tumor is like this. Here again you have the skin, here you have the pectoral muscle. The growing part of the tumor, the spherical one, unfortunately for this lady, is growing toward the pectoralis muscle, and it is infiltrating the pectoralis muscle, so this is a bad prognostic sign. But also in this case, the reduction in volume after 2 weeks of daily treatment, intra or peritumoral treatment, so here we're not talking about systemic, subcutaneous or intramuscular, here we are injecting the new GcMAF molecules directly into or around the tumor, and we can do this thanks to ultrasonography. The reduction is about 43% in volume. This also is interesting because this is a fibrocystic disease in a woman with a multiple myeloma. With ultrasonography, of course, we cannot monitor the effects of GcMAF on multiple myeloma because we have no access to the bone marrow, and even if we had access with the ultrasonography, we would not see any defined lesion. But by chance, this woman happened to have cysts in her breast, which were completely unrelated to the myeloma, of course. But as you know, you find fibrocystic disease in about 50 to 60% of all women in perimenopausal age, and also fibrocystic disease is due to non-malignant, non-tumoral, abnormal cell proliferation. And here we saw, and this was a kind of a surprise, because we were scanning the breast as part of a total assessment of this woman, not related to the multiple myeloma, of course, but here we saw a reduction in volume of about 68% of this cyst in the right breast after 2 weeks of treatment. So as of today, we do not know what happened to the multiple myeloma. We should know this when we have the blood exams, but we can say that this lady is responding very well to the effects of GcMAF because we saw such a dramatic reduction of the volume of this cyst. This other lady had stage 4, or maybe more than that if there was some other stage beyond the 4, of pancreatic carcinoma that had spread all over her abdomen. So she had a peritoneal carcinosis with acidic fluid, and she was in terrible pain. Now, following the suggestion of a colleague of mine, Dr. Jeff Presley, who also is injecting GcMAF directly into the peritoneum, into the acidic fluid in other patients with other types of cancer, we did the same, and we could not measure here the size of the tumor for the very simple reason that the tumor was so spread that we could not find an area that we could measure reliably and then say that it is reduced, it is shrunk or what. But we could measure the acidic fluid. In ultrasonography, acidic fluid is black, so here you have the right kidney, and all this black area here is acidic fluid. 2 weeks later, the same kidney, and you see that the acidic fluid is much less. Then you go left, this is the left kidney, this is the spleen, this is the acidic fluid here, and you can see 2 weeks later, no more acidic fluid is present there. Of course, the lady is feeling much better, much less pain, and she is struggling, she is striving to fight against this cancer, when in her home country, she was given just a few days to live. And we think she has much more than a few days to live after this treatment that, of course, is combined with the nutritional plan and with all the other complementary therapies that Mr. Noakes just told you about. Now, in my opinion, and considering the latest results that we have had, all the papers that have been published by 100 and some scientists for the past 20 years, there is no doubt that GcMAF is very powerful against cancer. Now we have to try to understand why is GcMAF so powerful against cancer, and why the so-called new GcMAF is about 200-fold more potent than the old one. Well, we and others recently demonstrated that GcMAF, at variance with what Professor Yamamoto had hypothesized 20 years ago, has many more effects in addition to stimulating the immune system that then in turn will attack and destroy the cancer cells. Because we and others demonstrated that GcMAF directly inhibits cancer cell proliferation, and it reverts neoplastic phenotype. To make it short, it makes cancer cells to become normal. It also inhibits cancer cells-induced angiogenesis. I will explain what this term means. And of course, it stimulates macrophages that will kill cancer cells. If you Google my name over the internet, you will find out easily that I'm not popular with the HIV/AIDS establishment. Actually, they hate me and they never invite me at their conferences, but I've been invited to 2 world conferences on AIDS only because of GcMAF. So nobody wants me to speak about HIV, and I will not speak about HIV today, but even the HIV/AIDS establishment accept our research on GcMAF, maybe because they realize that it is important for them too. So this slide was presented in 2011 when we were working with the so-called old GcMAF. We did not have the new GcMAF at the International AIDS Society World Conference in Rome. You can see the Colosseum and the AIDS ribbon here in place of one of the windows of the Colosseum. Here we have human breast cancer cells, and we were looking for vimentin expression. What is vimentin? It is a protein that it is expressed, that means it is present, when cells become more malignant. It is called epithelial mesenchymal transition. So when cancer cells become more malignant, they have greater potential for metastasis, they express this protein. Here you can see that we exposed the cells for 3 days to 40 nanograms, please remember this number, 40 nanograms of GcMAF, and we saw a significant effect on the expression of vimentin. That is a reversion, an inhibition of vimentin expression. So this meant that these cells tended to become normal. Why I want you to focus on the 40 nanograms? Because 2 years later, that is just a few months ago, we did the same experiment, but this time with a new GcMAF that we call GOLAIC or GcMAF oleic acid. And here I show you, just as I did before, the entire plate. So I do not like to select one particular region of interest. I could have selected this region filled with cancer cells and this region completely void of cancer cells. I don't like to do this, so I show you the entire petri dish. In the upper panel, you see the human breast cancer cells growing like mad and trying to fill every space in the petri dish. If you treat this with 0.2 nanograms, it is 200-fold less GcMAF oleic acid after 24 hours instead of 72 as seen before. You can judge by yourself. You still see a few cancer cells, but I think that there is no need for any sophisticated analysis of images to visually assess that there has been a strong inhibition of cancer cell proliferation and induction of cancer cell apoptosis. So now this is why we can say that the new GcMAF molecules, which are more physiologic, they are about 200-fold more potent than the old ones, at least in vitro. The effects of GcMAF on angiogenesis. What is angiogenesis? Tumors, solid tumors, cannot grow more than 2 millimeters in diameter unless they produce factors, mostly proteins, that promote the growth of new blood vessels which infiltrate the tumor and bring the supply of blood, oxygen, and nutrients. This is a very well-known concept for the past about 30 years, thanks to the pioneering work of Judas Folkman in the United States. We can study angiogenesis in a variety of model systems. We chose the chick embryo chorioallantoic membrane, so here you see a fertilized chick embryo. We open a window, and then in this little sponge that we implant in this membrane, which is the equivalent of the human placenta, we can put whatever we like. In this case, we place human breast cancer cells inside the sponge. We published this paper in Cancer Immunology Immunotherapy in 2011. And so here you see the number of blood vessels that are converging toward the center of the sponge because they are attracted by the factors released by the human breast cancer cells. You pre-incubate them with GcMAF, and you can see a significant reduction of blood vessels. This means that the tumor does not receive enough oxygen, blood, nutrient supplies, and therefore it becomes starved, and it is easy prey of tumoricidal macrophages. So let's talk about macrophages activated by GcMAF that attack, search and destroy, Americans would say, cancer cells. These results have been presented at the International Meeting of the European Society of Gynecological Oncology in Liverpool just a few weeks ago. And this slide here represents a big breast cancer cell attacked by a number of small macrophages activated by GcMAF. Dr. Rod-Smith will show you some movie about this. I'm presenting just still frames. Okay, so these big cells here are human breast cancer cells. You can see the multitude of activated macrophages that are trying to surround these cells. They're looking for these cells, they want to destroy them. Go to a larger magnification. This is a big cancer cell, and you can see all the macrophages around and on top of it. For those of you who are familiar with histology, if we go at a larger magnification, you can see that the cytoplasm of the macrophages is vacuolized. This means that they are ready to perform their task of killing and then eating, as the name macrophage says, the cancer cell. Again, now the big cancer cell, all the macrophages around and the macrophages on top of the cancer cell. But I think this is interesting, and I think you will notice that this is the big cancer cell. You see these two macrophages, they are deconstructing, destroying the cytoplasm of the cancer cell here. You can see this very well. But you can also appreciate the same action of this destruction of the cytoplasm here, and less evident here, but also here. Also here you can see that the shape of the cytoplasm of the cancer cells is actively destroyed by this macrophage with its cytoplasm fully vacuolized. It is working, destroying the cancer cell. Here you can see two cancer cells, one is this one and this one, attacked by a number of macrophages. This one is in the middle, is fighting two enemies at the same time. But this one has already attached to the cytoplasm of the cancer cell. This one here is destroying this part of this cancer cell, and this is coming to the rescue, is about to come and attack this cancer cell from this side. And all these others, they are coming and they are destroying these cancer cells. Again, you will see much nicer movies of this, of what is happening thanks to the work of Dr. Rod-Smith later on. Another picture, same process. This is a big cancer cell, this is another one, and here you have macrophages destroying. And for those of you who are familiar with molecular biology, this is a typical sign of apoptosis, that is the destruction of the DNA, fragmentation of the DNA inside the nucleus of the cancer cell. These are two pictures, still frames of the movie that Dr. Rod-Smith will show later on. And here you can see the cancer cells adherent to the plate, and the small round macrophages moving all around. Here they're still, of course, and killing them after, I think, 7 days. Nothing remains but only new plastic macrophages, and here a mass of dead apoptotic cell bodies, these dead cancer cell bodies that will be taken care of by the macrophages. This leads us to the definition of eradication of tumors that was originally proposed in 2007 by Professor Yamamoto. As he wrote here in the abstract, after about 16 to 22 administration of GcMAF weekly, these patients had significant low serum enzyme levels, and this indicated eradication of the tumors, and the therapeutic procedure resulted in no recurrence for more than 4 years. What do you mean as eradication? This is another clinical case. This guy had liver metastasis this big that they did not fit the field of the ultrasonography machine. So this is a liver metastasis of about 12 centimeters. About 80% of his liver was substituted for by metastasis. This picture was taken 1 year after GcMAF treatment, conjugated with a very severe nutritional plan, very severe and very strict exercise plan. So this guy did everything correctly, and 1 year after, the metastasis was still there. It was quite disappointing. But with the ultrasonography and then with MRI, I was able to demonstrate that this was no longer a growing metastasis, this was scar tissue. For those of you who are familiar with ultrasonography, and those who are not may come to the course so that we can teach them some tricks, all this white appearance of this metastasis indicates that this is no longer a growing tumor. You may remember that the growing tumors that I showed you before were black, up to the point that you didn't see them. This is white. White means fibrous tissue, and you may recognize a capsule here. This is a regular liver, normal liver, and this is the capsule surrounding the metastasis. So, is this eradication? Well, we decide. There are no longer growing tumor cells. There is a scar tissue, which is 12 centimeters in length. So, unless you are a skilled radiologist, you may think that the metastasis have remained there, but the guy would not have been alive with a metastasis of 12 centimeters lasting for more than 1 year, so this is most important. And actually, this is no longer a growing tumor. This is scar tissue. So when you talk about eradication, you always have to define the terms of what you are talking about. And now I am toward the end of my presentation, and I apologize if I become too boring, even more boring than I've been so far, because I will talk a little bit about molecular biology. And I will try to answer two questions. Why is the new GcMAF so potent? And how? This is a criticism that we often receive by the ignorance. By those who ignore that what happens for GcMAF also happens for cortisol, for insulin, for a thyroid hormone. That is, a single molecule, in this case GcMAF, is effective in a variety of pathologic conditions ranging from cancer to autism, chronic fatigue syndrome, chronic kidney disease, neurological disease, Parkinson's, Alzheimer's, multiple sclerosis, ALS, as well as in conditions associated with environmental pollution. How is it possible? Well, it is possible, and we are proud to be among those who elucidated the molecular mechanism of action that is responsible for such a variety of effect and led us to design these new molecules that are so potent. Let's go back about 3 years. 3 years ago, when I was not working with Immunology at that time, I was still working with Professor Yamamoto. Again, even though I'm so unpopular with the AIDS establishment, they invited me to present my results on GcMAF at the World AIDS Conference held in Vienna, in Austria, in 2010. 25,000 participants from all over the world. And at that time, we first noticed that GcMAF, at the time we were working with the GcMAF prepared personally by Professor Nobuto Yamamoto, and we noticed at that time that the responsiveness of human individuals to GcMAF was dependent on the genetic polymorphism, that are variations, of the receptor for vitamin D, or VDR, vitamin D receptor. So, 3 years ago, we noticed that GcMAF was a signaling, that is, was transducing its biological signal through the receptor for vitamin D. And we have been working very hard in the past 3 years to try to understand how this was possible. We published these results in the Journal of Nephrology, because as I told you, GcMAF could be very effective in chronic kidney disease. And now, please forgive me if for about 5 minutes I abuse your patience describing this new model of GcMAF. Now, please imagine that this is a cell membrane. It is, of course, cell membranes are not straight lines. So here you are inside the cell, and here you are outside the cell. This ribbons is the way that we represent proteins in modern days. On the outside of the cell, you have GcMAF. On the inside of the cell, you have vitamin D receptor. Both proteins are vitamin D binding proteins. One is the receptor, and the other derives from vitamin D binding protein. We discovered, thanks to biocomputational analysis, that the amino acids in the region where GcMAF binds vitamin D and in the region where VDR binds vitamin D are almost identical. This is the way we represent amino acids with one single letter. When we made the alignments, as we say, and with the computer program we checked for similarities, you can see that the yellow or green colors identify